Is it working? Good afternoon. Okay. Okay, everybody get settled in. Okay. Call this meeting of the Health and Human Services Committee to order. Let's get on the road. So we should now have a quorum. And if the rules chairman will, wait a minute. If we have a really quick one, is it okay to me to let the really quick one go? I hate to. I think he's almost a freshman senator. How long have you been here?
I'm just barely past being a freshman.
Just a third year? Well, his is a little his is a little longer and a little bit more important. You're welcome. So, Senator Martin, if you'd like to come forward and present Senate Bill 52, we'll welcome you to the Health Committee. I mean, all bills are important. Could you tell that to a few of the senators over on the other side that are only having meetings where they're having hearings only?
I'm not sure the rules chairman caught that, Madam Chairwoman.
Oh, was he talking? Okay. Go ahead, Senator Martin.
Thank you, Madam Chairman of the committee. I appreciate you letting me go first so I can get to transportation at 3 and make sure I pass that good House bill out of the House Senate Transportation Committee.
Good. Okay. Thank you.
I'm presenting today Senate Bill 52. And simply what SB 52 does, back in 2014, we passed a bill that allowed LPCs to sign Form 1013s or 1013 forms, which allows for transportation to emergency receiving centers so that people can be determined if they're mentally ill and need to be admitted into that facility. This simply does away with the sunset. We've been doing that for 2 years now. We expanded the sunset last year. It's been a very successful program. It's working well, so we'd like to do away with the sunset. If there are any questions, I would take them now.
Okay. Are there any questions for the senator? Okay. Seeing no questions, is there anybody in the audience that is just burning to speak for this bill? No? Okay. I'm ready for a motion.
Make a motion to pass.
Okay, I have a motion that Senate Bill 52 do pass and a second. Any other discussion? Everyone in the favor of the passage of Senate Bill 52, say aye.
Aye.
Anyone opposed, say no. No. It looks like the ayes have it. Senator, thank you very much.
Thank you, Madam Chair.
Just remember how nice we are in health. They're not even listening. I said, just remember how nice my committee is, and how they voted, and there were no votes, and if there was a no. Did you do that?
He has nothing pending in Senate rules.
Well, that'll help.
Just remember us as bills come up, and how nice my committee members were for you over there. Thank you very much.
Thank you.
You're welcome. And Mr. Senate Rules Chairman, and my friend from up in the mountains, if you will come forward and.
If I could bring my partner, my political partner, I got it.
So this.
Can we take a picture?
Madam Chair, it brings emotion to be here in front of such an esteemed committee, and I want to thank you of your kindness to me and the members of the Senate, and also for being the co-chair of this study committee in which this bill came out of. I think that I and you and Representative, the man from Pickens County, I know you are. Jaspers, Hank Kimball on Green Acres, Ed Harbison, myself, Butch Miller, and who was the other House member? Bruce Broderick. Is Bruce here? Anyway, we found a lot of information, a lot of issues regarding this industry. And the interesting part is the industry brought this to us, saying that there's some problems with this.
And this is Senate Bill 88.
Senate Bill 88. And I'll give you, with your permission, I'll give you the 30,000-foot look.
Okay.
And since this is apparently a moving bill, and only by your kindness, Josh will give us a more detailed version of it. And I think Representative Jaspers will be handling this on the floor if y'all see it through this esteemed committee.
And there is they have provided us with, right by your bill, 2 sheets that sort of walk you through different sections if you committee wants to get them.
Okay.
Okay, so we're ready for our
30,000 foot look.
we are.
Well, this is called the Narcotic Treatment Programs Enforcement Act. I represent Northwest Georgia near Chattanooga, Tennessee. I have Alabama on one side and Tennessee on the other side. And our surrounding states have a much stronger certificate program to open up treatment facilities than Georgia does. So right on the state line at Tennessee, Catoosa County, a county populated about 68,000, has 3 with 2 applications pending. And there's 68,000 people. Gwinnett County has more than 1 million people and has 5. So you can tell there's something wrong with that many right there on the state line. It's because Tennessee is so strong in their application process. They're only 1 in Chattanooga, Tennessee. So they're all in Ringo trying to get patients. And it has alarmed my community of why this is such a case here. So we have created an application program that will make it so that the person who wants to open up a treatment facility has to prove the need of the facility in a community, has to have public input, has to have law enforcement input, has to have the health community input. They got to prove the need before one is open. My area, there are 6 with 2 pending within 10 miles of Chickamauga, Georgia. Now, we have a lot of faults and a lot of problems, but we don't need that many facilities. Here in the Atlanta area with millions of people, absolutely, I'm sure you do. So this is to take a balance to make sure that only a facility that is needed in a community has the opportunity to prove their need before they fill out the application process. And that's kind of like the 30,000 foot approach to this. And in your packet, do you have this too?
Should be.
We have divided the state into judicial districts as far as how many can open in the judicial district. So you can see Gwinnett County is 1 district, Forsyth County is 1 district. My area, there are 4 counties. It's a population kind of thing, but you can't have population bills, so that's how we decided to divide it up. You're on? Any questions from my end? And I'm sure even Mr. Pizzo would, with the community input, would probably be in favor of something like
Okay,
this.
before you leave, Mr. Chairman, questions for the chairman before we let him go? Are you staying?
I'm staying.
Okay.
I'm honored to be in front of this esteemed committee and proud to offer any assistance from my little old committee if I can help any of these members. I need a motion. I apologize.
Okay. Can we list all our names and tell you our bill numbers?
Absolutely, Madam Chair.
Okay. Well, I don't have any. I don't think any of mine have made it out of committee, so that's one of those things.
If they were in my committee, they would be first on the list.
Thank you,
Madam
sir.
Chair.
So there's no questions for the chairman before we go on. Okay, you're on.
All right, thank you, Madam Chair. My name is Josh Mackey. I'm representing the opioid treatment providers of Georgia. We have worked with Senator Mullis and Madam Chair and other legislators on this for the last year. We also have Jonathan Cannell. He's the president of the opioid treatment providers of Georgia and a clinic owner himself. Just to kind of go back to square one, last year there was a bill passed to institute a moratorium on the licensing of these programs. We've had a large increase, probably over 30 that have opened in the last 5 years. And with that moratorium, as Senator Mullis mentioned, we did a study commission, joint House and Senate, and what came out of that was the reality is that we have the easiest application process in the Southeast to open up one of these programs. That doesn't mean that the programs are bad, but most of the other states around us have instituted a CON or a very strict application process.
Well, let me ask you, for the committee, because I know what the answer is, but if we have such an addiction problem in our state, then what's the problem with having all of these? So I think you need to explain that to
Yeah.
the committee, why this plethora
So
of all these is not a good idea.
the first thing I would say is that this association is made up of the treatment providers. Many of them have been in this business for multi-decade. They consider themselves advocate. We don't consider this an anti-treatment proposal. And I can guarantee you that there will be more programs that open up in this state under this. But the issue is that because some of our border states have instituted a CON, and because we had such an easier process to open one, we have people opening up clinics here just to service other states and their needs. Now, in healthcare, we don't believe in borders and lines. People in Northwest Georgia go to Erlanger Hospital to get treated. And so these people from other states can come here. But this is a process to help balance out where we need treatment across Georgia, in addition to, we can't service the entire need of the state of Tennessee because they may have a CON. So this proposal balances out all those aspects.
But isn't one of the main problems that, basically these are methadone clinics?
Correct.
And in one of the things we're trying to do is improve the treatment, because methadone basically doesn't help you with your addiction. It just gets you addicted to another drug. And one aspect of the programs is supposed to be therapy, that they're not just to hand out a medicine, that they're supposed to be treatment. And these ones that are opening up with a plethora do not always do that. Is that correct?
Yes, I think a lot of people in the industry would argue that it does help people get off of their addictions over time. But the reality is that if you walk into these programs, 90% of the square footage is a counseling center, and only about 10% is a medical facility. Now, they do have physicians and NPs and PAs and pharmacists, et cetera, on staff as they're required to do. But these are large in part counseling centers. And what we're doing in this bill is we're not prohibiting anybody from owning or operating a clinic. We're not targeting any specific group, but we are saying that you or the people that you bring in to be a part of it have to have a knowledge base about this treatment and about healthcare.
And that you do counseling.
Correct.
Get him to say it.
And that's
Go
and,
ahead,
and, and
Josh.
it is part of one thing I'll also mention is that this area is very regulated, both from the federal and state level. To open up one of these programs, you have to go to the DEA, the Department of Community Health, Georgia Drugs and Narcotics, and the Department of Behavioral Health. They're very regulated, and there's very strict federal regulations in regards to the counseling that you must be providing.
If I can say something too, and thank you, Madam Chair, for bringing that up. One of the sole purposes of the treatment facility is to get people off drugs, and counseling is a key factor. We believe many of these new ones are not fulfilling that need. Now, Mr. Cannell and his organization, and one that is on in Rossville, Georgia, I've visited. They have, again, more counseling offices than they do the other side,
Right.
and that is a routine, a steady part of the facility is to treat, to talk, and to counsel these people that are on drugs.
That's it. Thank you.
All right, I'll try
Just
to
go
go
ahead.
through this as quickly as possible. All of you should have a summary in regards to SB 88 in your folder for LC number 372410S. The first thing I'll say is that in that summary sheet we provided you, there's 13 sections in this bill that are in current law, and the reason we have these listed out is narcotic treatment programs, detox, everybody is regulated under the same article in Georgia Code right now. It's very vague. We had to pull narcotic treatment programs out separately and create a new article in the code, and that necessitated copying a lot of current law into that article so that we didn't leave out any sort of regulation that is already there. So there's about 13 sections in this bill straight from current law. If you have questions about those sections, you can know that they've been in code for over 30 years at this point, and haven't arisen to show any problems. The meat of the bill begins in 26.546, that section. We're creating an open enrollment period for applications, and where this has come from is we're obviously getting a lot of applications for these programs at the state. The state is shorthanded when it comes to surveying the currently licensed programs, and there's a long process and wait to get your program surveyed for an application. So the goal of this is to harness the time period that the state will get the program or get the applications so that they can begin to prioritize the surveying of current licensed programs, and then prioritize after open enrollment the applications. So it sets forth a specific open enrollment at the end of this year, and then after that, the department would set a biannual or annual open enrollment. In addition to that, there would be two requirements that any applicant would have to meet. They'd have to attend an information hearing and also send a letter of intent within 7 days of the open enrollment period to the department stating they intend to apply. So it would have to meet those two requirements. 26547, this is where we get into the meat of the application process that we're starting to create. In that section, we create 12 new things at minimum that the department must form rules and regs about for the application process. They include such things as Senator Moles mentioned, seeking community input, and we've listed out examples of community input. We specifically say you do not have to gain community input, but you have to prove that you actually reached out to entities, whether they're local elected officials, Rotary clubs, Kiwanis clubs, and sought out involvement. You do have mandatory law enforcement notification. You do have to report data in regards to patients at current programs within 75 miles of your proposed location in the region that you're in. A lot of what we've pulled from this are the better parts of the North Carolina process because they chose not to go the CON route like we're doing, and so we've copied that. Probably the best thing in this section, though, is, as I mentioned, there's 4 entities you have to go through to open up one of these programs, and 2 of them are 2 separate state agencies. At the very beginning of that section, we've put together DCH and DBHCD and said that after the open enrollment period, they will jointly review the applications so that there will be a regulatory and a clinical perspective when deciding if these programs should move forward in the process and be licensed and be surveyed, et cetera. I think that's actually one of the functionally best things that we're doing in this legislation. Moving on to the next session, this is 26548, probably the meat of the bill. This is where the map that you had handed out to you comes into play. In trying to address the problem of treatment and where programs are being located, we went through a number of maps and came up with a concept of splitting the state into regions. The map you have in front of you closely follows the judicial circuit regions for the state of Georgia, and the reason that we chose these was there's 49 of them, and that we could put a limitation on the number of programs allowed per region without affecting other population areas. If we used public health or any number of other regional maps, limiting programs in one area could spill over into another close by city. So what we've done with this is we've said, these are the regions of care. You can have 4 programs per region. We're grandfathering in all licensed programs right now. So as Senator Moles said, there's over 5 programs in his region right now in Northwest Georgia. All of them will be grandfathered in. Nobody will have to close down. And we additionally, there are only 4 regions that we're proposing that meet that 4 program cap. And we've created a waiver process in the law to allow an applicant to show, hey, we think there's a necessity for another program. We want to put it in this area, and the department will have full discretion on determining whether that waiver to submit the application is approved or not. The other thing that we've done in this bill is that we didn't want to provide any negative ramifications when there's a change of location. Currently, if you move your location because, say, you're growing because we are in the middle of an epidemic and you need to serve more patients, we've kept the process the same if you're moving your location within the current region that you're located. So it's just simply notifying the state, filling out a basic form. After that, 26549, we are prohibiting what's called bounties. Bounties is a referral from a current patient to bring in new patients. This is actually in current rules and regs right now. We're just putting it into the effect of law. And then the other 2 subsections of that part, we are trying to address a very critical issue, what is commonly referred to as $1 a day. There are programs out there that are advertising a temporary discount, $1 a day of service for the first month, which is a very, very deep discount. What we're aiming to do with that is prohibit people from advertising a temporary discount and then changing their fees within the first 90 days. This industry wants people to come, seek treatment, and get the full circle of medical treatment and counseling. And the current owners and the current operators have felt that that practice is not really in keeping with being honest with your patients about what they're going to have to do to get off of addiction. So in that section, we've done that. Probably the other big change we've done is 26561. We have instituted a fingerprint background check for the applicants as well as the administrators. An administrator is defined from the rules and regs, and we've put it into code to say these people will have to do an NCIC fingerprint background check. Currently, Georgia Drugs and Narcotics does a non-fingerprint background check for these people. We're simply taking it to that next level, which is very standard when it comes to nursing homes, personal care homes, and other healthcare facilities. That's the major parts of the bill. I know I probably maybe talked a little too long, but we're happy to answer any questions.
We have questions, Representative Reinders.
Thank you, Madam Chairwoman. I'll try to be brief. I'm assuming this is what we talked about offline if we opened up a certain code section in governmental affairs?
Yes.
Great. Can one region under this plan, can one region contest or have input into the opening up in another region?
No, because the region isn't
So-
like a governing entity itself.
So, hypothetically, if we have one sitting in Albany, and we recognize the need in Region 47 for another one, can the providers or the clinics in Albany object to the need in Region 47 under this current proposal?
In no more capacity than they could now. I mean, I guess they could call the department.
That'd be a
and-
yes.
And say it.
That would be a yes.
There's no formal process to do that. We're not granting any.
But in the
powers.
interest of full disclosure and competition, then if you have a cap of 4 in each region, could that not be problematic if we're allowing another region to potentially have veto or at least some financial interest on what goes on in another region?
Again, we're not giving any authority or capability to do that. Anybody now could
But
go
there's
to the
nothing that
state.
prohibits it.
No, there's nothing that prohibits it. There's nothing that enhances it or gives that
And the department
direct
will
power.
decide, let's say they're at their limit, but there seems to be another clinic that wants to open. The department has the ability to grant that if they see the need. They gotta
Or deny it
or deny it. They gotta see.
because of the objection came from another region is my point. And we've seen that movie. Going on, if I may, what allows us in the future to be able to change the region if we see? Is that done just through department, or can we legislatively change the region if we see a population growth or an increase or an
This
uptick?
is part of the bill, so we'd have to do it legislatively.
Thank you so much. And then finally, is there any cost associated with this?
No, because there's no requirement on new surveyors. We did that.
I
open
just would hate for
enrollment period.
DCH to come
Yeah.
back to us next year and tell us how we gave them an unfunded mandate. Not that we've ever seen that movie before.
Well, let me tell you, there is a need for more surveyors, but it's not in the budget, so that it doesn't happen until they're granted. But during our lean years, we cut back everywhere, and this is one area we probably should enhance, but it's not here.
Thank you. And Madam Chairman, I just want to say for the record, I have some concern about us in each region. I believe in that, but I just have a little concern because of one region being able to potentially provide input in another region, and I don't know if there's a fix for that, but thank you so much, Madam Chair. Thank you.
I don't think that's in the bill. Anybody can object to anything, you know, so, but the department will, if it's at its max, they gotta prove the need in the community. Anyway, thank you.
Mr. Connell, do you have anything you'd like to add since you?
No, ma'am, I think it was, I mean, it was answered.
Okay,
We're good.
all right. Okay, I don't have anybody else signed up to speak on the bill that oh, wait, we've got more questions, sorry. Representative Silcox.
Thank you, Madam Chair. I just wanted to say I appreciate you bringing this bill so much, Chairman Mullis. I have some personal experience from my family with this, so I think this is going to improve the quality of care that people are receiving, and I think it's good for the state. Thank you.
Representative Jaspers.
Thank you, Madam Chairman. Jaspers, no.
Didn't I say that?
I did, I'm just looking
I
at
said it
Chairman
too.
Mullis, I'm just teasing.
Man from Pickens County, I do that a lot, you know.
I do, I'm teasing you. But I guess for Mr. Mackey too,
in this bill, you know, Chairman Cooper talked a lot about treatment. And does it show in here amount of time someone will be treated? Where does that fall in, or just is that in department regulations?
We haven't outlined that in this bill, but I think Mr. Cannell could answer that.
As far as your question is how long? I'm Jonathan Cannell, the president of the Opioid Treatment Provider of Georgia, and also treatment program owner. So your question is how long someone should be in treatment? Is that your question?
I guess, how long do you normally do it? And I guess, was it specified? I kind of glanced through it, Mr. Chairman. Did we say that someone has to have 15 minutes a week, or is that something that's done within the industry or through departmental regulations?
So we also are accredited just like hospitals. So there is accreditation that, so when someone actually, because when I hear the treatment, it's number one, the length of time someone is in treatment. That's typically a question we get. But as far as there is no mandate on how many counseling sessions someone is required to have per week, if that is your question. No, there is no mandate on that. If that is your question.
It was.
Yes. No, there is no mandate. Individual and group counseling is required. As an industry standard, the newer someone is in treatment, the more aggressive treatment they have, and if they're struggling. So if they're struggling, they're relapsing, they're having problems, then someone is required to have more treatment, not less. And so more group counseling, more meeting with their individual counseling, and that a lot of times is dictated by their urine drug screens.
Gotcha.
Also, Mr. Chair, if you would tell them all the governing authorities that regulate your
Yeah.
industry.
So we are,
Federally and
yeah,
state.
so we are regulated by DCH, by the Georgia Department of Community Health, Federal Department of Community Health, CSAT, DEA, the Georgia Drug and Narcotics, which is the Georgia Board of Pharmacy Board, and then we're also accredited just like hospitals. So accreditation is a federal mandate. And that started in 2002.
Have another question. Representative Barr on 14.
Thank you, sir. Mr. Cornell, I've talked to Mr. Mackey about this as well. Being a small business owner, I just have angst when we mandate, and I know this is a heavily regulated business, but prohibiting discounted fees for 90 days. Could you just kind of walk us through that, and since you are the business owner there, help us understand why we're doing this?
Yeah, so we are dealing with the addicted population, and we are dealing with a highly susceptible population of people that are in a desperate place. So let's be clear, we give out medication to address the physical needs of a person's addiction. So they're physically dependent on a medication, such as a prescription pain pill or heroin. They come to us, and those withdrawals, it dictates their thinking. Those of you who have had experiences, I think somebody said earlier, so it overwhelms their thinking. So they go to a place, and at the time when they come in treatment, all they want to do is take those withdrawals away. So any program can give them medication to take their withdrawals away. So if you were to offer someone $1 a day to come into a program to take their withdrawals away, I mean, I would do it if I was in their shoes because it's a cheaper, more affordable place. But what we've seen as a provider group, that doesn't necessitate quality treatment. Because just as it was brought up before, medication alone, that addresses their dependency. It takes the withdrawals away. But addiction counseling and good provided recovery services, is what allows people to find recovery. So as a provider group, we have seen this practice of $1 a day be very detrimental to our industry, and we do not think it's a good practice. And as a small business owner, I agree with you. I think incentivize people to come into recovery is a great thing, but in this situation, it provides very bad business practices and potentially puts a very susceptible population of people at risk.
Yeah, on that, Madam Chair, we're dealing with people on drugs, not best cable service or a phone service or something else. So I think you need to have the medical profession in a good place, not trying to just sell it away, but to.
Well, and one other thing, though, I mean, we do give out discounted services. I mean, if there's a pregnant girl that comes in our facility that cannot pay, industry standard, and the majority of our programs give that service away for free. So we are not saying something like that. If I have someone in one of my programs that is indigent care and that has on a fixed income, yes, we actually reduce their services, but not as an incentive to get them into a treatment program. We're looking at for a needs-based service. So there's a big conversation. I can understand your concern, because if I was in your shoes, I would probably hear the same thing as a concern. But it's just a very broad conversation, and we do not think it's a very good practice at all.
Thank you. Representative Price.
Thank you, Madam Chairman. Now, are the people who would avail themselves of this program coming in for a cure or for help with their dependency?
Yes, that would be true. It is for help. when
For,
they're at that point.
but the presumption is that they're going to go cold turkey, that they're going to.
No, ma'am. I mean, yeah, we'd love to find as a country a cure for opioid dependency. But yes, they're coming in for treatment, meaning they come in and they do take medication. I would say probably 99% that come into a treatment program take medication, along with individual and group counseling, and which is all defined by their treatment plan.
And it's outpatient.
Yes, ma'am, it's all outpatient. If someone actually shows where they cannot do outpatient treatment, and then according to ASAM, we would actually refer them to a more intensive intensive care.
And we all know that people do fall back and don't necessarily succeed the first time.
Yes, ma'am.
So if they go back out and have issues with using needles, is there any correlate with this as far as needle exchange programs or harm reduction?
We would love to see a needle exchange program, and it is very much listen, this is what our industry used to be known as harm reduction, but that is no longer what our industry is considered now as harm reduction. If I have somebody in my program that's smoking marijuana and taking medication, am I going to kick them out of my program because they're, a long-term opioid dependent person? No. We want to keep them in services so that we can actually give them more treatment, not less. So it's not a punitive basis of treatment. And this is not the providers group. This is Jonathan Cannell speaking. Needle exchange program is desperately needed because of the infection rate with HIV and hepatitis C. Not that we're condoning drug use. That is not. Do not hear me say that. I'm not. None of us condone drug use. It's the whole idea of getting someone in to receive education about drug
Well, I
treatment.
know this is in a different code section than a bill that's floating around regarding needle exchange programs. Is there any way you would accept an amendment with this, even though it's in a different code section regarding needle exchanges?
Representative.
Madam Chair, I'm just asking in terms of what would potential germaneness in the same code section that we get sometimes being asked on the floor. And I just didn't know if that would be germane, not coming from the same code section, if it may be problematic.
Madam Chair, we rely on the wisdom of this committee, and I have a high regard for Dr. Price, but I'd rather not take a chance. I'd rather work with Dr. Price on another bill, another issue, and on that kind of subject. If that's okay with you, Dr. Price?
Certainly, we're looking for a vehicle. If you could help me find one,
I
I'd be so
will.
happy.
I like the song, in fact. You know how that goes?
Looking for a vehicle?
No, a vehicle, that's the song.
So, that's fine. I think we need to
Spencer Fry
probably
would know
not
that
take
song.
any chance with this on germaneness. So we pass up on that one. Representative Drenner.
Thank you, Madam Chair. I'm just curious. I have two questions, if you don't mind. The first one is, so you're going to allow 196 facilities in the state, basically based on your 49 regions and four programs per region.
Well, I doubt that would ever happen, but if it was full, I guess it would, but I can't imagine it happening. Currently, we have 70. Florida has 69, and they're double our population and more. Tennessee has 11, and they're a little more than half. So we have a little bit more than we should for our population currently. I'm sure others will open, and I hope they do in places that are needed. But I'm glad that you did your math, Representative, but I don't think that would ever happen.
Well, my question was, is that the number of facilities, did you base that on the projected number of potential applicants that you might have in the future? No.
We were trying to find a realistic number that worked for our problem that we have in Georgia. And again, there are exceptions that the departments can agree to say there are bigger need in this community. Mine would not be it. I'm overrun in facilities currently.
Before we came to that number, we did look at some analysis from the federal government and SAMHSA, the regulatory body over it, to make sure that there wasn't a place of stark need that we would be capping with that if there were a rush of applications, and it doesn't appear to be that way. In addition, there is no limit per se from the federal or state governments on how many patients a given clinic can see. So in theory, how many ever number of clinics, it's really more about geographic location and proximity than, you know, per se maxing out on the number of patients.
Can I ask one follow-up question, Madam Chair? Can you tell me what's the failure rate of someone that goes through treatment and has to go back again? Is there a metric that you all track?
So is there do we have a statistics as far as failure rate?
You probably don't call it that, but.
Yeah, can you give me a little bit more definition, because I mean, of specifically what
So
you're
if you've
asking?
gone through treatment one time and then
Yes.
you had a relapse,
Yep.
and then
Okay.
you have to come back to treatment.
So it typically takes someone 3 to 4 times of entering treatment before treatment actually starts to take hold. And that's in all forms of addiction medicine. So it really speaks more to the aggressive nature of addiction and the disease itself.
Okay, Representative Lott.
Thank you, Madam Chair. On lines 257 to 261, I just want to make sure, the gentleman had stated that they do give indigent care and pregnant mothers discounted rates. And I just want to make sure that those lines do not interfere with what they do currently. For the sake of everyone, of course, narcotic treatment programs shall not provide discounted fees for services during the first 90 days of treatment. So this is just a clarification question.
It doesn't say except for pregnant women. Isn't there a federal law in regards to that?
We're trying to hash this out
I
here,
gotcha.
okay?
I believe it's a credit, I mean, federal. So from the CSAT prohibits us from denying treatment to pregnant women, and so we are required to treat them.
And so I just really want to make sure,
So-
because I understand that. I
Yes.
want to make sure that we are not limiting you by these lines. The bill and all other forms I'm good with. I just want to make sure we don't put you in a corner.
Yeah, we could be open to amending that section to provide that exemption. However, I think federal guidelines would prohibit it already. And then there is current law 26549, line 314 of the bill, that requires immediate access for pregnant females. That's something that's been in code for 30 plus years. One of those sections we were moving over. I mean, if you wanted to provide that additional clarity, we'd be open to it. But I think between that and then federal reg, you know, we'd have to do it, regardless of
So,
ability to pay.
if I may, Madam Chair, no,
Okay, go ahead.
please feel free.
Madam Chair, what I'm wondering, if I just heard, what I heard was we're not sure if it interferes with federal regs or not. Perhaps the thing to do, the posture would be, at the worst case scenario, is to offer the amendment. If we find out it's not necessary, then you could agree to go to conference for the sole purpose of being able to strike it. And that'll give you time to look up whether it's in federal reg, if you think that's the
Sure.
appropriate strategy.
Madam Chair, whatever you think, but you could put except for pregnant women and indigent care, perhaps, something like that.
Okay.
I think if you wanted to keep in concert with current law, you would say copy what's on line 316 for the exemption and say drug-dependent pregnant females.
Okay. At the proper time,
Yeah, we
You
would
wanna
have to add indigent to that as well.
Representative Lotz, I was just trying
it's Representative Lott's amendment.
Okay. And I would ask to do that. I make a motion that we amend this portion. And please, can you state that one more time?
You'd want to provide an exemption for drug-dependent pregnant females.
And I would like to add indigent because if that's something that he's doing, are you comfortable with that?
Yeah, it's
Yeah.
fine. Absolutely.
Look, help me figure out where. Yeah. Can we let Betsy figure out if it needs to be, I would like Betsy to look at this to see where it needs to go.
I would
On
recommend
which line?
Okay.
line 261 to put it in that, because that's what actually prohibits the discounted fee.
Josh, would you be saying except for?
Yeah, you could say except for drug-dependent pregnant females or indigent patients.
Okay. Betsy, are you comfortable?
That's after line 259.
I think you would want it for section C though also.
Can we add it to both sections?
Yeah. That works.
Yes, ma'am, I like that. I'd like to make a motion.
Recognized.
I'd like to make a motion that we create an amendment to this bill with a section D, which states, provided however this shall not apply. Doesn't need to say this code section, but this code section shall not apply to drug-dependent pregnant females and indigent. What was her word? Or indigent patients. We're gonna get this.
You have any discussion on the amendment by Representative Lott? I've seen all those in favor, aye.
Aye.
Oh, pardon me. Excuse me.
Make sure that the author of the amendment is agreeable that if we find that that's not needed through federal regs, which was part of our concern initially, that we then agree in conference to be able to strike that amendment.
I am in agreement with that.
Me too. Let's all hold hands.
Yeah.
Okay. After discussion, anyone opposed? Same segment? No, okay. Amendment passes. It's added.
Motion to pass as amended, or substitute rather.
We have a second. Any discussion? I see a 10. Sorry.
Thank you, Mr. Chairman. I apologize, but I did want to ask, just to make sure there's nothing else that went into this about the free services. When we added the indigent, I understand the pregnant females, but when we add indigent, that seems to imply that if you had an indigent patient who was able to refer, you could give them free services. They would be exempt from this bounty, free services, or I'm just thinking that the indigent, you wouldn't be able to give free services if they refer someone. I was wondering if we'd want to keep it.
Well, we're talking about the dollar pill scenario to bring in business like it'd be some milk battle at the grocery store. We're trying to provide medical quality service here and try to get people off of the bad drugs and other that need treatment.
That answered it. Thank you.
I don't think I answered your question.
Well, no,
But, if there is a need for indigent care, and of course, we believe that federal code section takes care of the pregnant lady that's that's addicted, but.
and it seems clear that you would not be.
That's right.
It wouldn't be in exchange for referrals or anything. If you're doing indigent care, it's because you care about people regardless of their ability
That's
to pay.
right.
Not.
Thank you. Recognize Chairman Riders.
Well, I was going to ask a parliamentary inquiry to see if we had not already passed the amendment.
We did.
But
We did.
That's the correct posture we're in. Thank you.
We're just letting Representative Newton ask a question. So, Madam Chairman, would you like?
No, go ahead. Practice.
You got a motion in a second? I'm good. And All in favor, please say aye. Those opposed, same like sign. None. So that we have
Thank
do
you.
pass, passing LC 2405S, a substitute,
As amended.
as amended. Thank you, Madam Chair.
Thank you, Madam Chair. Mr. Chair, members of the committee, let me know how I can be of service to you. Thank you, Matt Hatchett, too, and for the buttermilk in my committee today.
Just a minute, Mr. Chairman. I
Yes,
want
yes, dear.
to compliment you on your attire for the day, especially your tie. It's certainly in good taste.
Thank you. May I say that I'm honoring Dr. Cooper. He was a great man, and the chair gave me one of his ties, and I thought this would be a special occasion to honor Dr. Cooper.
Thank you.
Thank you.
So, if, I know there are people here to speak on House Resolution 447, but, you know, I have gotten words, and, you know, we're running sort of late for this, that we're going to need to postpone that, and because we have other meetings and members are going to back up against it. So I thought I would tell you now if you want to leave and get out before the Atlanta traffic gets bad. I'm very sorry. I apologize. But it's that time of year when we're just backing up on top of one committee after the other, and I've been given the notice to not get into a long discussion and sort of cut it off. So thank you for coming, and I do apologize. All right. Senator Underman, you're next. Let's do Senate Bill 4.
Okay.
You okay?
Thank you. Muller's been sitting here. I can't get in the seat.
Oh, he.
He's got short legs. I got long legs.
I thought maybe it was because of how far back you were. Did I say that?
No, you didn't say that.
So.
Okay. So, I bring before you Senate Bill 4, and this is the Enhancing Medical Health Care Treatment Act. The proper name is Georgia Mental Health Treatment Task Force. And this bill, fortunately, evolves out of the legislation that created Representative Katie Dempsey's study committee from last year. And she did a fabulous job. And she and I were working together. And unfortunately, I didn't hold up my end of the deal because we ran out of time. And she was so gracious. I went to every one of her mental health task meetings except one that I had a scheduling conflict. So this is a continuation. I think it's just as good as hers, and the purpose of it is to look at mental health, and I think it's very appropriate to be doing that at the same time that the federal government is changing the healthcare infrastructure. One of my main goals is parity with physical health with mental health, and that's one of my goals when we start working on all these waiver programs from the Fed. So I think it's very appropriate that at the same time we're analyzing that drawdown money that we'll be having this task force. It is a large task force, and I know some of the representatives asked me about some other members. I counted up. There's 17 total on it. I believe Matt asked me about a psychiatrist, and we do have that opportunity to put a psychiatrist on it, one member from a private freestanding psychiatric institution, and that could be a psychiatrist. It's equal, Senate and the Lieutenant Governor and the Speaker appointing 3 members, and then it's got all the department agencies. One of the most important things I learned from the teachers group and the education groups to be sure and put the advocacy groups, and there will be 2 representatives appointed from the mental health advocacy groups. Acute hospitals are included with inpatient psychiatric beds. As you know, there's a dilemma and continues to be a dilemma with DBHDD and the influx into the emergency departments with wait times and the backlog with mental health patients having to stay up to 3 days in the emergency facility. One of the things that another representative asked me about, Representative Rakestraw asked me about substance abuse. Substance abuse is included in this, and with the opioid epidemic, just like you were talking about the medication assistant treatment programs, it is included in here, and substance abuse and addiction therapies will get equal access in this committee, and I'm committed to that. So I'll be glad to answer any questions.
Questions from the chairman? Okay, we have no question. Okay. Chair, who we got? Representative Hatchett. Well, let me get, who's this right here? Huh? Representative Price first, excuse me. I think she was first.
Thank you. On line 61, do we ever recognize like the DSM or choose to?
I didn't understand. What was the question?
In defining mental illness, or
What was your question? I didn't
using
understand.
whether or not as part of the definition we would use as defined in the diagnostic, whatever that is, the DSM book.
I don't know the answer to that.
Is that a problem, Representative Price?
Well, I just don't like to see, loose definitions, but I mean, it's pretty tight in that book, as it defines, different levels and all that sort of thing. But, I mean, it changes from year to year, but I just wondered if some reference to that book might be helpful.
I think the terminology that I'm used to, that I've been working on so long, is Ms. Whitten drew this up, and it correlates with the current code of mental illness.
Okay, let me ask Betsy, you want to weigh?
Yeah, I didn't reference the bill, but I think she might have used the definition in Title 37, which is our mental health code that defines it that way. We do, though, to answer your question, in various parts of the code, we do refer to the DSM for various reasons. Not sure how we would do that right now with this definition or how that would fit in, but I think this comes from another area of the code. Many people in involuntary hospitalization.
Okay, thank you.
Okay, so it has been referenced, Betsy thinks, in the other part of the code, but, is there any more discussion on that, or? Okay. Representative Hatchett.
Thank you, Chairman Cooper. Chairman Underman, you mentioned what we had talked about. Is it possible that we could put in there somewhere that this, I guess on line 82 that you said, one member from a private freestanding psychiatric institution, could we put who is a practicing psychiatrist or a board-certified psychiatrist? Or, does institute mean a teaching area, or is it just, can that be?
No, I think a
clinic?
freestanding psychiatric institution would be like, I know Northeast Georgia has a private, a lot of the hospitals have private freestanding. I don't have a problem with that. I just don't want to preclude, like, if you wanted to put the administrator, he could be a psychiatrist and an administrator.
But he might not be.
But he might not be, that's right. But,
I'd really rather put just another member to your board.
well, there's
I'm
17 on it now.
Just make it 18.
Well, Representative Hatchett, if you wanted to go up to line 80, you could. Put
That's
one-
fine. I don't care, as
one-
long as they
Okay.
show up and work. That's what I care about.
Okay. Well, what about on line 79, after designee and before a representative, after that comma, adding a Georgia licensed board-certified practicing psychiatrist?
That's fine.
Okay. And I would like to make that a movement.
Okay. That will make 18 members.
Yes.
Is that agreeable? Rather than striking like one representative from the mental health advocacy group, or? Madam Chair?
That's fine with me. I don't care. Like I said, I just want them to show up and get appointed, and do a good job.
Okay, but I mean, do you want to keep it at 17 and we reduce one
Well,
person?
typically on these committees, we have an uneven number because when you're voting, you don't
Yeah.
want to have to get into the argument about who breaks a tie or whatever.
Right, Representative Hatchett, do you want to change the amendment that you've offered to say, besides the Georgia Licensed Board Certified Psychiatrist, do you want to go down on line 80 and change the 2 to 1 representative from mental health facility to keep it at 17?
That's fine with me. Is that okay with the author?
That's fine.
Okay.
Okay, so we have another question. Representative Bennett, you have a question about?
No, ma'am, pass. That was my suggestion.
Oh, okay. All right. So there doesn't seem to be any other, before we take the amendment, who we got? Right. Okay, is there anybody that wants to speak on the bill in the audience? Don't have anybody signed up. Okay, so let's look and get a posture on the main bill first. So what do we have? No, I'm gonna take it. Okay, do I need a motion? Okay, I have a motion to pass. Do I have a second? I've got a motion to pass and a second. Okay, now let's take up the amendment. Representative Hatchett's amendment is on line 79 after designee, a Georgia licensed board certified psychiatrist,
Practicing psychiatrist.
practicing psychiatrist, sorry. And then going down on line 80, after association, you would strike through 2 and put 1 representative from
Mental health advocacy.
mental health advocacy groups. It's okay, everybody understand what the amendment is? Do I have a motion on the amendment?
So moved.
I've got a motion on the amendment, seconded. Anyone in opposition to the amendment? No, hearing none. Okay, the amendment's passed. Now back to the bill. Is there any more discussion on the main bill as amended? Okay, Representative Reinders.
Thank you, Madam Chair. At the appropriate time, I would like to add an additional amendment.
Okay, this is the appropriate time.
Thank you, Madam Chair. In the order, make sure we've got the proper house cleaning. On line 153, after the word abolished, with the hopes that I can clearly read what was written for me, and this code section shall stand repealed on January 1st, 2018. Is that right, Ms. Betsy?
Okay, you wanna read it again?
Yes, ma'am. After the line abolished, after the word abolished on line 153, we shall add, and this code section shall stand repealed, is what we're adding between abolished and on line 153.
Okay.
Just a little cleanup.
Okay. I take it that you make the motion for that amendment.
ma'am,
Do we
I
have a
do.
second? Does everybody understand the amendment and what we're doing? Any questions? Okay, no questions. Everybody in favor of the amendment as offered by Representative Reinders? Okay with it? Say aye.
Aye.
Anybody approved? No? We've got it. Okay, now back to the original bill. Representative Lott, did you have an amendment that you wanted to make? Or not? You're okay. Or was it Representative Price? It was Representative Price. You're okay. All right. Well, we have a motion to do pass as amended, and we've had a second on it. And everybody in favor of the passage of Senate Bill 4 as amended, it'll go out as a substitute, say aye.
Aye.
Anyone opposed? No. The ayes have it. Okay. All right, Senator Underman, your second bill is Senate Bill 242.
Yes, ma'am.
We're not moving it. If you pass it out. Pardon? Let me have, who doesn't have a copy? With 242. John, I need a copy. Me? No, I don't, we didn't have it. Okay, is everybody ready? Okay. I mean, this came out just before. Mr. Clayton, can I see you for just a minute up here? You have to hold, Madam Secretary. Just a second. I have a question.
What, Katie, I didn't see you in here. I didn't even see you. I'm sorry. I was talking about how wonderful you are. You gotta be on this next one.
Sorry, this came out at the last minute, and we really haven't had very much to take it. We'll have to hold a question. Go ahead and explain the bill. I have a question about ordering drugs and on the ones for the emergency writing people. There's some discrepancy on whether they write prescriptions or not.
Oh, okay.
And it says order, and
Okay.
I just want to get it right.
Okay.
Okay, so go ahead and explain the
Okay,
bill.
so I appreciate y'all looking at this. This is Senate Bill 242, and this changes the existing APRN, Advanced Practice Registered Nurse agreements with, protocol agreements with physicians and supervision of APRNs. As you know, a few years ago, we changed the law allowing minute clinics to exist. And I was very hesitant, and we held up that bill for a couple of years. And turns out I think they've done real well, that they fill a necessary gap in the system, that people who have earaches and sore throats and strep throat can be seen because of the access to care issue. I know in my particular area, we have lots of folks that go to these clinics because the other clinics are full. And they do relieve the burden on the emergency settings and decrease the cost of care. This particular bill passed the Senate 52-0. And what it does is increase that protocol agreement to have a roster of APRNs. Unfortunately, of the about 150,000 nurses we have in the state of Georgia, we do have a shortage of nurses, and in particular APRNs. And this has become very evident in the retail setting because you have to create a roster. And unfortunately, when you create a roster, sometimes people get sick, sometimes people get pregnant, some people don't show up for work. And in the retail setting, and there's folks here that can speak more adaptly about this than I can, but I can only imagine that if people don't show up for work because they're not on the roster, then you have to shut down the clinic. And obviously, when you shut down the clinic, you're decreasing that access to care, and also the corporation that owns the clinic is losing money. And that's exactly what this does. This increases the roster up to 10 in the protocol agreement with the physician. I think that was a good number, considering the shortage of nurses and being able to pick up enough people to staff a clinic. I asked to come forward some of those business people that run these clinics and let them tell you firsthand experience that I can't describe. It also has a requirement of a review of the medical records to monitor the quality of care, and that review is at 10%. I think it's pretty self-explanatory. It passed without any questions on the floor of the Senate, and it passed 52-0. Passed out of the Health and Human Services Committee without any amendments or any negativity.
Okay. Questions for the chairman? Okay. We need to make a couple amendments to it. Skin, you want to offer those? I asked Skin, who's a lawyer who brought part of this bill to our attentions about the ones working in the drugstores.
Yes, ma'am.
So, and apparently, I don't know how legislative council does the job they do, especially in the cryptic notes that they get from us and the number of bills they're moving and changes they're moving. It's a wonder. Nothing would come out right if it was left up to me. Okay, Skin, if you want to.
Madam Chair, I'll be glad to. First of all, let me thank Senator Unterman for bringing this measure, and also I want to thank Madam Chair. She also brought a similar measure on the House side, and we appreciate their interest in this subject. Two suggestions on the amendments, and this was based on very detailed discussions that the authors of the bill and myself and other interested parties had with the Medical Association, the family physicians, and others. We thought it would be appropriate on line 39, after where it says agreements, and Betsy, I'll defer to you, but my suggestion was, after agreements, comma, may not authorize the prescription of Schedule II drugs pursuant to said nurse protocol agreements. So, yes, ma'am.
Already under this code section, an APRN can't prescribe Schedule II drugs, so it's already out.
Very good. Okay.
Even if that's a change and they were allowed to order them, it's out of this section?
They can order it anywhere in any of these locations.
Okay. Would it include, okay, we were going to offer it again on line, down for the ones under the top part of the bill on line 34.
Yeah, same thing. The word drugs on line 35 is defined as dangerous drugs and controlled substances. And controlled substances includes everything except Schedule I and Schedule II.
I don't think I,
Can you say that again?
yes, please.
Okay, the word drugs is defined earlier in the code section to mean both dangerous drugs and controlled substances, but it also further defines in that code section controlled substances as everything except Schedule I and Schedule II. So the word drug there on line 35 is already designed to include Schedule I or II.
Okay, but would there be a question, Betsy, over order drugs? To me, order means would it be prescribed?
Well, again, we're trying to use the definitions that are already in the code section, and it already defines order as it means to prescribe pursuant to a nurse protocol agreement, which drug, medical device, medical treatment,
Okay.
in writing, orally, facsimile, or electronically. So that's the word used in the code section to mean prescribe under a nurse protocol.
Okay, so it's covered, so that in either of these situations, even if we allowed nurse practitioners to give hydrocodone, they would still not be able to do it under this code section. Okay, so we don't need to change that part. Okay.
Very good.
Okay, Representative Reinders.
Thank you, Madam Chair. Just because I got two lawyers and I respect them and I just can't think as quick as y'all. Tell me the downside, Betsy, anyone, tell me the downside to adding to make sure that we don't show legislative intent to eliminate the confusion on ordering.
From my opinion, that if we specifically said that, it would first of all be superfluous language that would really do nothing, and then it also sort of suggests that maybe they can in some other areas of the code section. We don't carve it out every time we use the word drug.
I think that's correct, yeah.
All right, I'm going to defer to the experts, but I just want to make sure we eliminate the confusion on the ordering. So,
There's no confusion.
okay.
Yeah.
All right.
And the other thing is, I don't have a substitute, so I'm not looking at what you're looking at.
Well, it was hot off, I'm sorry, Senator, it came hot off the press.
Does somebody have one?
Here you go.
Yeah, right here.
Renee.
Thank you, Madam Chair. I'm just trying to make sure we cover our bases.
Okay. Okay. And I had some questions about the 10% of chart review. Is
Yes, ma'am. Madam Chair, just to respond to that, if I could, that is around the states very standard.
Okay.
There have been studies done that indicate that if you even increase that, you really, all you do is increase the cost to the providers and to the consumers, and you really don't gain anything in terms of quality of care. So that is something that's been done around the country, been found to be satisfactory. And I would remind the committee that you're also talking in this situation about a facility that has to be accredited, has to be recognized in that way, and in the other provisions in this bill. So you're dealing with someone that's doing things the right way. For instance, Minute Clinics, we partner with Emory Healthcare to help run our Minute Clinics. So we've got very good doctors overseeing these APRNs, and we think the 10% is adequate, and would urge the committee to keep it at that.
All right. Representative Silcox.
Thank you, Madam Chair. I was just curious if we're going to double the number of nurses, that we either, to me, if we're going to double it, we need to either have some more oversight, or what is the proportion in those states that they only have the 10% review? To me, we should either increase the percentage or not double it.
Let me be very clear on that. I think it's important. The current law says that the doctor can supervise up to 4 at one time. We're not changing that at all. Right. You'll still only be able to supervise 4 at one time. All we're saying is the problem is the current law also says you can only enter into 4 agreements. So if one of those 4 is out sick, is on maternity leave, quits the job, whatever, you've only got agreements with 3 then, and you can't staff up. This just says you can have agreements with 8, but you still can only supervise 4 at one time. So we're not increasing the level of supervision any one time.
Okay, then maybe just for clarification purposes, we could have that there are only 4 that are working at one time or something. We could clarify that a little bit better.
I think it's...
That's in the existing law, and all we're
Okay.
doing is changing the roster. And
Oh, I understand. It's
yeah.
a staffing issue. I understand that. But
Yeah.
my point is it still, to me, it's
On
not
line
clear that it's
38
4 at one time.
On line 38, it specifically says may not supervise more than 4 APRNs at any one time.
Okay,
You've got that right there.
okay.
Well, but of course, when you're supervising people at any one time, that doesn't mean you'd be checking the charts, just to be clear. I mean,
No, you're gonna be doing that following up.
following up,
Yeah.
so,
That's
I mean, I
that's
think that,
current practice.
I would also say, the committee, just to give you an example, Minute Clinics operate currently in 33 states. Of those 33, 24 have no limits whatsoever,
Right.
none.
And
Another,
physician assistants don't either, do they?
right,
well,
another,
it's not about how many they have,
It's the roster.
Scan. It's about how well they're supervised. I think
Absolutely.
that's what Representative Silcox
Yeah,
was.
I'm just
absolutely.
saying, we're still gonna be one of the tightest supervising states in the country, even with the passage of this bill. Most states would allow supervision of many more than we are even with this bill.
Thank you.
It's whatever you want to do.
I guess I would like to offer an amendment.
Okay,
That we either, at the appropriate time.
okay, at the proper time. Let's see, who we have, these are the ones. Eden Davis would like to say something.
Thank you so much, and thank you, Senator Underman, for bringing HB 242. I represent the Georgia Retail Association. I'll be brief. We just think this is a great bill, and I think this is a really good step for these Minute Clinics and other folks that are members of our organization as well. So thank you for bringing this, and hope your favorable consideration.
Okay, Marcus Downs.
Madam Chair, members of the committee, I'm Marcus Downs. I represent the Georgia Nurses Association. So I've seen this bill from a couple of different iterations, one from the medical side, now from the nursing side. I think Madam Chair Unterman has done a really good job in making sure that this does just address the number of contracts that you're able to enter into. One of the things that we are working hard from GNA's perspective is the nurse shortage. I think this definitely addresses that. I think this definitely looks at the safety concerns that we have for Georgians. I just made a couple of notes that I want to highlight. It requires that there's evidence-based guidelines and training, which is something that we always look for. It requires a good standard from the Joint Commission, which is something that we also look for. It requires clinical collaboration meetings with the physician, and that's something that is very positive. And then finally, it allows the patient to return to their patient-centered medical home within 24 hours of being seen by a MinuteClinic. So I think that there are plenty of safety measures in place for Georgians, and I think this is a very good piece of legislation. Ask for your favorable support.
Marcus, I want to disagree with you on something. This doesn't address a nurses shortage. The nurses go around and talk about a nursing shortage. But one of the things we have done, they're talking about that nurses shortage in our hospitals. And I'm fine with the mini clinics, but the mini clinics and the spreading of this kind of opportunity have taken nurses out of our hospital. Now, I'm glad for nurses to have opportunities of different kind of care, but it doesn't help our nurses shortage. It, takes them away from our hospitals.
I certainly
So-
respect that, and
Okay.
we've offered some solutions to definitely assist with the nursing shortage.
Fine. If we ever had enough data that the nursing association, the nursing board has the ability to get us, that would, maybe some of those propositions would move a little faster.
I can't speak to the nursing board, but I can
No,
definitely
okay.
assure
Well,
you.
unfortunately, the nursing association only represents about less than 3,000 members when there are 130-something thousand registered nurses in the state. So I know you're working hard to improve that, and I trust over a period of time that you will be able to do it. But really, the Georgia Nursing Association doesn't represent a lot of the nurses in this state. That's less than what?
Well,
Right now my mind's blank on the percentage.
I'm really glad that our 3 nurse legislators are members.
Yeah, that's right.
Thank
Thank
you.
you. And I was glad to work on this bill too with Senator Unterman on getting it through. Faye Fulton?
Yes, ma'am. Thank you, Madam Chair and the committee. My name is Faye Fulton, and I represent the Georgia Academy of Family Physicians. And I'd like to thank both chair ladies of the Health and Human Services Committees for bringing and working with us on this bill. The Georgia Academy of Family Physicians are very, very comfortable with this bill. We represent 2,800 members of board-certified family physicians, virtually 90% of all the family physicians in the state. The reason we really like this bill is because while it may be solving a roster problem for the retail health clinics, it solves a problem that the primary care physician community has had for several years, which is this bill will allow you, your grandchildren, your daughters who go to a retail health clinic because maybe your primary care physician's offices are closed. Within 24 hours, a notation of that is going to be sent to your primary health care physician's offices. And not only is it going to say what happened, the transaction, but who the nurse was that treated your granddaughter, as well as who the supervising physician is. A medically licensed Georgia physician. Chairwoman Cooper is well aware of the problem, which is right now, my doctors who are trying to outreach back and figure out the treatment that maybe happened in the middle of the night or on the weekends, they can't get the record. So this is solving a really big problem for the primary care physician group. And with that, I'll pause. Thank you, Madam Chair.
Okay, thank you. Skin, I know you're behind it, so you want to add to that?
I can't add.
So-
I would just thank you for the work on this bill, Madam Chair. You and
You're
Senator.
welcome. So, and like Faye said, after hours is good. I wasn't knocking the people that work in your clinics, but it has pulled out of our people that might have worked in our hospitals and, made our shortages more thing. Derek Norton.
Thank you, Madam Chair, members of the committee. Derek Norton, I represent the Medical Association of Georgia, and I'm come to speak to you this afternoon with some concerns we have about Senate Bill 242. MAG policy supports the current law, which allows 4 APRNs to be supervised by a physician. We've been involved in discussions with CVS to work out a compromise over the last several months, but those discussions involve adding transparency and possibly increasing to maybe 6 APRNs supervised. While we appreciate the added transparency language, we do not agree with increasing the number of supervised APRNs to 8 or 10. If this committee moves this legislation forward, we'd ask that you consider increasing chart review to ensure proper oversight for patient safety. Our physicians would submit that close to 100% chart review is best practice for patient safety, and as has been said, CVS chart review in Georgia is currently at 10%. which suggests that if you're going to double the number of APRNs, like Representative Silcox has already said, that you should also increase chart review. And finally, this has been represented or presented as an access to care issue, but there are only 30 to 40 CVS Minute clinics in Georgia, and almost all of them exist in highly populated areas. So we feel this is not a good argument for this increase. This proposal is profit-driven, not patient safety-driven. And with that, I will answer any questions. Thank you for the opportunity to
Any questions for
speak.
Mr. Norton? No?
Thank
No
you.
questions. Thank you. This is, Representative Jaspers.
Yes, thank you, Madam Chairman. I just have a question on the lady that spoke prior to Norton was on line 54 through 56. We're talking about the physicians, going back to primary care. Now, how's that going to be done, or how's it currently done? Is it done electronically by letter? They call them, or?
My understanding is it'll be done electronically, that the patient will provide the name of their primary care physician to the nurse at the retail clinic, and then the patient will authorize them to send a copy of that record to them, and they will do that electronically. They'll contact the office and determine how to get that done, but it'll be done within 24 hours as required by this law.
Continue, ma'am. How does that, I guess, is this part of the 10% that's looked back at, or how does that work?
No,
I
no.
mean, I'm just curious on how that's going to be enforced. I mean,
The 10%?
No,
No.
Of the 24 hours?
on number 5, yeah.
Well, they'll have to be in a record of the fact that you have sent that information to their primary physician, and then if the state board or anyone who's doing an audit or investigation sees that you're not documenting that and have not been providing that information, you have violated the law.
All right, thank you, Madam Chair.
Okay. Representative Dempsey.
Oh, no.
You pass?
But at the proper time, I'd like to make a motion.
Okay. It's the proper time for a motion?
To do pass.
Okay, a motion to do pass in a second. Do you, Representative Silcox, want to make a?
Whoops, am I on? Yes. I'd like to make an amendment, please, since I appreciate very much Senator Underman's bringing this bill, and I understand the staffing issues, but since we are doubling the number of nurses, I would like on line 47 to increase the record of review to at least 20%.
Okay, we have a motion to, on line 7,
Line
increase.
47.
Pardon?
47.
Increase the amount of charts reviewed to 20. Discussion? Okay. Representative Henson.
Thank you. Even though I haven't worked in a doctor's office, I've worked in dental practices, multi-dental, should I say, many dentists in the same practice. And I just know how difficult this is, adding the 20%. What you're basically doing is taking the doctor away from being a physician and putting him into reviewing charts only. I think we should leave it at the current 10%. If in fact there does seem to be a problem as we go along, then we could always increase it. But at this point, everything that we're hearing is that it would be very, very difficult. And as I said, from having run practices for close to 20 years, I just am saying that you're taking the doctor away from being a doctor.
Representative Henson, let me make this clear for the committee. This is not like a doctor's office. The nurse is working independently, just so the committee, in a mini clinic. And usually these are doctors that are hired. They're not in their practice doing this on the side. They're hired to, like, maybe retired or area doctors in the area that are hired to overlook it. So it's not like a regular practice where the doctor's there and the nurse is there at the same time. So they're not taking the doctors away from patients.
But here's my question. We're not increasing the number of patients being seen. We're not increasing the number of nurses that can be out there at the same time. There's only 4 nurses currently that he can supervise. There would only be 4 nurses supervised. We're not changing a single solitary thing except to add more to a list of, it's sort of like a jury pool. You put enough people into a jury pool so you can get the required number of jurors. And that's all they're trying to do with the roster is to get the,
Representative Henson,
get
you know,
four.
I understand that. I was just clarifying to
I
you
know.
that
Thank
it
you.
wasn't a doctor that was being pulled away
Yeah,
from
I hear
patients.
that.
That's
Mr.
it.
Mr. Chairman,
Yes.
can I just interject that I oppose the 20%? That the current law, there is no review. So you're already stepping it up a notch. And to go to 20%,
There's no review in the current law?
I don't think there is.
I
Current review of the charts?
requires periodic review, and then the board can set something
Right.
Okay. All right.
And 10%, as I say, that, the reason that was brought was that seems to be the industry standard. That's what's done, best practice. And I, again, would say, if you raise that, you're really only gonna be increasing cost to the clinic and the consumer eventually.
But to be clear to the committee, when we had the meetings, they did say that they have some states where they do require more. Some states.
But the vast majority, no.
Right. They did say that some states do require more. Representative Hatchett.
Thank you, Madam Chair. Just for clarification, right now, law says a physician can oversee 4 APRNs, right? And this is the same as in this bill, and the pool of APRNs they can be is 8. is
Yeah,
what
I
we're
would
saying
like
in
for it
this
to be
bill.
10, but
We're
you've
at
made it 8.
Oh, okay.
Yeah.
But only 4, but to make that clear, only 4 at one time. They're using the other 4 in case of illness and staffing so that they have, if somebody's sick, there's somebody that can go.
A trained pool.
So,
Thank you.
okay. No, Betsy said it was periodic, so this would be clear. Representative Petrie.
Thank you, Madam Chair. I just want to echo what my colleague here, Representative Henson, mentioned. Being a healthcare provider myself, it is customary. Not only do we do self-audits on about 10%, but even utilization review typically will take 10% of the charts. Anytime we increase that, we're increasing cost. We're at a time we're trying to drive down costs, not drive them up. And so I would be opposed to such an amendment. Thank you,
Okay.
Madam Chair.
Representative Silcox.
Yes, just to address Representative Henson's point, I think this is really a matter of efficiency, because I think if you have 4 people working and someone's sick, then I think that you're actually going to increase the number of people that have access. You're going to have more prescriptions. You're going to have more charts. You're going to see more people. You're going to definitely increase revenues, and I think proportionately that we need this amendment to keep that 10% for patient care, for patient safety.
Madam Chairman,
I feel like I should put it out for bid. Okay, I've got 20, you've got 10, can I take, do I hear 18? 15? I mean.
just one response to Representative Silcox. If you're seeing more people, by definition, if you do 10%, you're gonna be reviewing more charts. 10% of the bigger pie is more charts you're gonna be reviewing.
But you're going to see more people.
Okay. Representative Bennett.
Pass.
Okay, pass. Thank you, Representative Bennett. Representative Sharper.
Thank you, Chairman. I just want to go on record that I'm opposed to the amendment with respect.
Okay, Representative Reinders.
As long as I get respect, or Silcox doesn't, you know, I'm good or bad on any amendment. We've got some people, and I'm just trying to find what we're doing here, but I got some people sitting there going, the profit centers are going to go up, the amount of money made. We had a quote recently. I do believe we have a moral obligation to drive costs down, but I also believe we have a moral obligation to make sure that you have the efficiencies in place. So because I'm hearing this squabble a little bit, there's a part of me that thinks the easy solution to this is just to do what everybody else wants and just go with 15 and let us go home.
Let's just split the baby.
Are you going to object to that as well?
I am. I'd
Okay.
like 10%. And I'm already
I'm
agreeing.
trying.
I'm already agreeing to go down to 8. My desirable is 10. You know, I don't know what else you can do.
You don't
to
believe
Bill.
reviewing more charts is a bad thing. I know that's not your position.
Correct, we do, but all I can tell you is, we brought best practices here, and when we sat down and negotiated with the family docs, with MAG and others, We came up with this, you know, the 24-hour notification to the primary care. We came up with this other information. We cut it to 8, and frankly, the 10% was something we felt like we had to stick to because you're gonna cost more money without really getting any benefit.
Madam Chair, I'm going to say the final thing is, if it's your desire to have 20% to push it to conference committee, then as a member of Health and Human Services, I'll back my chair on this one, just so y'all can talk about it and come up with what you need to talk about. I'm following your lead, Madam Chair.
Representative, two more questions. Representative Sharper.
Thank you, Chairman. 10% and then we can go home.
And Representative Henson,
Or whatever you wanna say.
you have to be as short and sweet as he is.
10% and we can go home.
What?
10% and we can go home.
Okay. Representative Silcox, do you want to keep it at 20? Do you want to put 15? Do you want to not make the amendment?
I'm happy to go to 15.
Okay, so you want to, okay, what is your amendment then?
My amendment is just to change line 47 to review at least 15% of the advanced practice registered nurses.
Okay. Do I have a second? I've got an amendment and a second that we go to 15% on chart review, and that would be changing on line 47 and marking out 10 and putting in 15. Any further discussion? Yes?
Question, which is that, is that the only change? I've kind of lost in it here. That would be the only change in the whole-
No, we changed about the narcotics. No, we didn't make a change. No, we didn't make a change.
We didn't, so that would be the only change. Does that
Right.
make it any harder for it to get through at this juncture?
Yes, it does, because that makes it go to conference committee.
We're
Okay.
just getting late. so.
All right, so what we're saying is if this is the only change that's going to be made on it, it will mean that it has to go back over to the Senate. They would have to, if they don't want to agree with it, they have to agree to disagree. We'd have to come back and say, we stand our stance, or we disagree, and if we disagree, you know, to go to conference committee. So, yes. So the committee will just have to decide. Okay, Representative Bennett.
Just for clarification, Madam Chair, this will be the 10% of the 4 practicing nurses that are on duty at the time that they're seen. Is that correct?
10%
Yes.
of charts.
10% of charts.
For the patients that were seen?
Yes.
Correct, thank you.
All right. Seeing no further lights. So, all right, we have a motion on the floor. Everyone, and we have a motion and a second. So everyone in favor of the motion, say aye. This is amendment, the amendment. I think we're going to, okay, and everyone.
This is the amendment to back the House chair.
Or it could be the amendment to
To
back
ma-
the
to ma-
Senate
to-
chair at 10%.
Your senator's back, as it should.
It's it's my committee's decision on this. I mean, I'll go with, you know, if, right, change, or like line 47, change the percentage to 15%. Everyone, let's do this again. Everyone in favor, say aye. Let's put, okay, everyone opposed, no. I think the noes have it, and so the amendment fails. Right, so, Representative Dent, did you want to make a motion?
Yeah.
No, what I have, we have a motion on the, okay, got it. We got it. We got a motion on the floor for the passage of the substitute to Senate Bill 242. Everyone in favor, say aye. Aye. Anyone opposed? No. Okay, the ayes have it. Thank you very much, Senator Unterman. And, you know, be sure and fill out your form we send over a thing, but in rules required. And apparently the rules chairman is saying you have to come to rules, several times. He's telling the senators that. Oh, we are adjourned. Sorry, guys.